It's a pleasure to be with you today. This is my second time giving a GPT webinar presentation, and I welcome this opportunity to explain what I've been doing for the past year as a telemedicine hematologist. Last time I came a few months ago to discuss my inpatient hematology consult service for rural hospitals, and that's how I got acquainted with GPT. I live in Florida, but I cover hospitals in Florida and Georgia and other southern states. And today I want to discuss the outpatient hematology telemedicine experience. And I have a lot to share, and I'm going to do my best to cover some important topics, and then I'll open it up to questions and give you some information. I had an interview a month ago and a publication to call to your attention in a hematology journal talking about telemedicine for hematology. And that's the kind of thing we're going to be discussing. Our topics for the next few minutes are a discussion about the breadth of hematology services that are offered in a telemedicine heme practice, and a discussion about specifically about iron deficiency and how we're tackling that problem and managing it by telemedicine service. And finally, a review of some of the benefits and drawbacks of telemedicine practice for hematology practice. First, let me take a step back and remind everybody that telemedicine was already being discussed and being utilized prior to COVID-19. There was a gradual movement for outpatient telemedicine specialty consults in rural areas. And the challenge was really the technology challenge, how to get people to the place where they can do a televisit. Do they have to go to a clinic, a doctor's office? Was that a requirement for coverage, for reimbursement, for legal purpose? And then was the technology good enough? In rural areas, it may not have been great Wi-Fi or 5G. And I think all of us agree that now, after a year of COVID-19, it's now feasible to do outpatient rural telemedicine. Thankfully, the 5G caught up just in time, I guess you could say, so that now most, maybe not every, but many in most rural areas have access to 5G coverage. And then the inpatient concept, I'm going to review for a moment, even though it's not our focus today. Inpatient telemedicine had been already done for more than 10 years, and that was really focused on the eICU concept of getting ICU medicine better covered, critically ill patients, and neurology, psychiatry patients, stroke patients, so critically ill patients that need urgent evaluation, and rural hospitals just don't have access to those doctors to come in for urgent evaluations for a stroke patient, or maybe even if they have access, it wouldn't be fast enough. And so the concept is that inpatient specialty consults were already being talked about. And finally, in 2019, it was being talked about for inpatient to do every specialty, not just neurology and psychiatry. And that's the top section on this slide, shows you that the CMS already had this addressed in 2019, enabling rural hospitals to have specialty consults, not just neurology and psychiatry, but every specialty. And then, of course, a year ago, COVID-19 made telemedicine obligatory, not just in rural hospitals, but in all types of hospitals, in all types of specialties. And now, still to this day, inpatient consults in every hospital setting are covered through telemedicine are covered. The other concept is that licensing requirements for state licensing requirements for interstate practice were eased so that we can do this across state lines. That will turn out to be a problem in the future. And finally, on this slide, the cultural shift towards accepting telemedicine in the COVID-19 era, that people just accepted it had to be done that way. And I think all of us agree that that telemedicine is here to stay because of this cultural shift. And if nothing else, it wasn't just COVID-19; it was the new generation of people that prefer telemedicine to in-person doctor visits. For the inpatient concept, there was a lack of access to specialists in general, and I think that's the general GPT concept, is how to bring those specialists to rural and small non-rural hospitals. Some conditions require an urgent specialist evaluation, and that would be a case where you need a telemedicine doctor, just like I mentioned stroke. And those specialists who go to rural hospitals in a part-time way aren't able to suffice. So now focus on hematology. In addition to the concept that rural hospitals don't have access to enough hematologists, there's known to be a national shortage of hematologists, oncologists, if for no other reason, just because there are so many people who need those services. And many of these providers prefer to stay outpatient. So the inpatient coverage wasn't that well covered, especially in rural areas. And there are too few hospital-based non-malignant heme experts, because heme-onc doctors tend to wind up doing more onc than heme for a lot of reasons. And I'm coming to all the heme issues in a moment, but I just want to give the bird's eye view here. Some heme conditions require an urgent evaluation in the hospital, like APR leukemia, and hematology is an integral part of hospital workflow, like pre-op and peripartum evaluations. And I want to remind those who watched me a few months ago that one of my drivers to start a telemedicine practice was to solve the public health problem that APL leukemia, acute promyelocytic leukemia, still has 20% death in the country, about 200 deaths a year in the United States, even though we're able to cure almost everybody else, shown in the green dashed line, that we can cure those who are identified. But the first week is a life-saving week, and those 20% who succumb to APL leukemia are succumbing because they're not caught in the rural hospitals by in hospitals that don't have a hematologist. So I sought to solve that problem, and I created what I called Hem-on-Call, the first telemedicine-only hematology practice. And our mission has now evolved into, we're going to be the hematologist everywhere, anyone who needs it, inpatient, outpatient. We're going to solve this problem of lack of access. And we started doing inpatient consults, and we've caught some very sick patients, including an APL leukemia patient, and we've saved lives during the first year. And already 8 months ago, I published this in the ASH Clinical News about how we're going to do telemedicine and revolutionize hematology, both inpatient, outpatient. I'm going to focus now on the outpatient issue, which is that many hem-onc providers prefer to do oncology, and hematology, even on the outpatient side, is limited. There are not that many hem-onc doctors who embrace hematology and do it as a specialty. Sure, they do it because they're required to do it as their specialty. They are hematologists, and it may be that some are better than others. But what you find is that hem-onc doctors kind of sigh when they see a hematology patient, like it's not their main interest or main focus. In fact, they may not be paid as well to do it. So it turns out that there's a problem, that outpatient hematology is limited. And then along these lines, what you have is, on the second bullet, hematology patients often wait a long time for an appointment. And it turns out that that's not always acceptable. Hem-onc doctors have a lot of patients that are very busy with cancer, and it turns out that to see that urgent hematology evaluation may not be so easy. So you have, especially when it comes, let's say, a pregnant patient, we're going to come back to that, who can't wait a few weeks to see their doctor, a hematologist. They need something quicker. The third bullet, hematology patients often have the patients often have a focus on their blood test results. For example, ITP and anemia. It's a lot about the numbers and a little less important to have a physical exam, an in-person physical exam. So that's one of the things about outpatient hematology, that that the patients recognize this, and they especially younger patients don't see the need to go in person to see a hematologist, and a lot of times they'll skip their appointment if they don't think it's important. The same idea, hematologists, the fourth bullet, they feel out of place in an oncology office. It just doesn't make sense in our modern era that hematology, which is now much broader than it used to be, is blended with oncology. That's the way it evolved, but that's not so good. It's not working so great. So finally, hematology patients have already been doing telemedicine all these decades, because what they do is they do blood tests. Now we do blood tests in blood test collection centers, and they don't necessarily have to go to the doctor every time they get blood tests. And they call the doctor or email the doctor or text and say, what are my results and what do I do? And that's already been happening. That's telemedicine already pre-COVID. Now, the other thing, I'll give you an example of curbsiding. Last week, when or 2 weeks ago, when the Janssen vaccine story about vaccine-induced thrombotic thrombocytopenia, when that story came out, I had no less than 30 requests in the first day for review of their situation. People that had that vaccine and needed a quote curbside. What do? I had this vaccine. Do I take an anticoagulant? And we do these curbsides. We hematologists, we give free advice all over the place. And I don't mind giving free advice. It takes a lot of time. The problem is that there's liability with that. I have to know the whole story before I can give legitimate advice. And it takes a long time to do all the advice that I'm asked to give. And there are not that many of us expert hematologists who are available to give this free advice. So I think we have to find a better, more organized way to give this quote curbside advice. And these are some of the problems of outpatient hematology. So the solution that I proposed, beyond the inpatient concept for me as the first telemedicine hematologist, the solution I proposed was to see a specialist online who focuses on non-malignant heme. Now that's me, and there are many other providers in the country who would be able and willing to do this. I'm trying to organize it for all of us to do it as a team. So far, this is a practice that I started with several advanced practice providers, and we're doing non-malignant heme online, and we can see the patients within a day of request online. No need to wait and see the doctor in their doctor's office. And so we can see them online, and the lab testing, which is sort of the main obstacle for a hematology practice, can be done in other places. I don't have to do the lab testing myself. I can have a phlebotomist go to someone's house, or the patient can go to private labs. That's mostly what's happening, like Quest and LabCorp. And they can also have lab testing done in their other providers' offices. And I'll tell you how it all works. The priority in hematology is now shifted away from whether or not we need an in-person physical exam, and much more about what's really gone on for decades in hematology is we're going to review data. We're the data analysts. A lot of times we're the mystery solvers of hematology, and we are going to educate patients about their lab test results, their conditions. We'll answer questions and take a good history and ask questions, but I think, don't need to do in-person physical exams for the bulk of our patients. So these are the conditions that we have now tackled. And I will go into depth about some of these, but I'll start with the general concept that hematology is, and more appreciated now that I'm doing this full time, hematology is intertwined with women's health. I would go as far as to say is that every OBGYN provider needs a hematologist, at their arm's length, because all these conditions are really blood disorders and blood conditions that the OBGYN doctor is seeing. And a lot of times the other primary care providers who do women's health. In South Florida, I've been focused on interfacing with the OBGYN community. And I've discovered over the past year, seeing my first 600 outpatient telemedicine patients, 500 of them have been women's health hematology. And I've discovered that this is really an unmet need. All these issues. You have heavy menstrual bleeding associated with iron deficiency. So these are women who have bleeding tendency. That's the second bullet, bleeding tendency. Sometimes you have women who may or may not know they have von Willebrand disorder. We can prescribe tranexamic acid, TXA, and we can set them up for IV iron. I'll come back to that. And then how about pregnancy-associated iron deficiency? This is now appreciated to be a big problem. 25% or more of all pregnant women in the country have significant iron deficiency. And this is a problem that was not solved by the system we had in place before in-person hemonc practices. So that's a problem. Infertility and pregnancy loss, a lot of times the hematology referral is desired, or these curbside consults, does the patient need anticoagulant to stay pregnant? And there's controversy about this, but at least I can be available to patients online to address it. And of course, you don't need an in-person evaluation for that kind of consult. You just go through the history and the lab testing and discuss what, my impression as a clotting specialist. Clotting in pregnancy, similar idea. If a patient's in the hospital, then they're going to hopefully see an inpatient consultant, possibly me, for rural hospitals. But outpatient, they can discuss their anticoagulant decision-making. The low platelet counts, a big problem. Low platelet counts, gestational thrombocytopenia, ITP in pregnancy. The OBGYNs have a wide variety of experience and a breadth of a wide variety of recommendations for this, and probably no single standard approach. And as a hematologist focused on low platelet counts and ITP, I can deal with this in a more consistent way and guide patients. And finally, a new one, I think, counseling about clot risk for oral contraceptives. You have all kinds of genetic testing going on and discovery that people have a clot tendency, like 23andMe testing, that people discover they have factor V Leiden mutation. So they asked their OBGYN about oral contraceptives, and I think that the answers are inconsistent. So I can see patients online and provide consistent guidance. All of this is online stuff. A whole nother list of set of patients that I can see online that I have been seeing over the past year. We've seen 600 over the past year, outpatient telemedicine consults. And the bariatric surgery patients that need iron, the people with clotting, anticoagulant questions, holding anticoagulants for procedures, bleeding tendency in women's health situations, hemophilia patients who need their factor, ITP management in general, ITP, sickle cell disease, we're tackling and trying to solve that. I know that's a big problem in Florida and Georgia. And I think that sickle cell access to care can be solved by doing consults on the phone. Myeloproliferative disorders, including polycythemia, essential thrombocytosis. We have chronic myeloid leukemia patients, which are more non-malignant sounding than malignant these days. And finally, some malignant type patients, including MGUS, and we're partnered now with the Dana-Farber myeloma precursor study to see MGUS patients who don't need to go to an in-person hemonc doctor to get education about MGUS. They can do it online themselves if they're willing and able, or they can see a telemedicine provider to get followed for MGUS and learn about it. So now that I've described the array of hematology services that we're offering, I want to explain a case about iron deficiency and tell you why I think this is so important. And I consider this to be now my crown jewel of the crown jewel of our hematology telemedicine practice, that we're able to see and treat so many iron deficiency patients so much more easily. And here's an example of a patient. This is somebody I would see pretty much every day. A 27-year-old young pregnant woman who's 29 weeks pregnant. She's been tired, short-winded. I ask her how much ice she's chewing. Of course, all of us providers know that ice cravings associated with iron deficiency, and the concept of pica, the concept of what's called pagophagia, the ice craving. And you find that her hemoglobin is extremely low. Her OBGYN doctor referred her for those numbers. And it may not have been a focus of the OBGYN doctor that she was craving ice, although we all recognize that's an iron deficiency deal. So most likely this is iron deficiency. You'll realize here that it's not proven yet, but you get the picture that this is an iron deficient type patient. And I'll say that this patient needs iron testing to prove it, although it's hard to believe we're going to actually want to take more blood out of her since she's got so little and more iron out of her. We do need that iron testing to treat her. So we'll have her go either back to her OBGYN for labs or to outpatient lab diagnostic clinic and get those 3 tests. It's that easy. We do the iron tests. And my job as the hematologist is going to be to interpret those tests and decide whether or not she needs iron infusions. And the whole concept of giving iron infusions, that's a whole nother lecture we can do next time. But the concept is that maybe she does, and we have iron infusions. So I'll just review the 3 major categories of anemia to clarify it the way I see it as a hematologist. You have the majority of people with anemia having iron deficiency. That includes women with heavy menstrual bleeding, pregnant women, bariatric surgery patients. We have now 200,000 new bariatric surgery patients a year in the US, so we're up to millions. And we have people with GI tract pathology, including peptic ulcer disease, diverticulosis, GI tract malignancies, inflammatory bowel disease. So you have all these different types of patients who have iron deficiency. The second row talks about non-iron deficient, non-malignant, like people with hemolytic anemia, including sickle cell, and special rare diseases, including things like hereditary spherocytosis that a hematologist would think about. And finally, heme malignancy patients with leukemia, lymphoma, and multiple myeloma. So these 3 categories of patients, and the bulk of patients with anemia have iron deficiency. It's important when you're thinking about giving iron to a patient to sort it out and decide whether or not they're an iron deficient or a non-iron deficient patient to treat them correctly. A common mistake about treating iron deficiency patients is the concept of seeing an alpha thalassemia patient and by accident giving iron without doing the iron testing. So that's something that I can help sort out as a hematologist. So I believe that all these people with anemia, and especially iron deficiency patients, should see a hematologist, and now we have that readily available. This is the pregnancy story. Starting around 20 weeks, the baby and the placenta start to take iron from the mom. it increases as they get towards third trimester. And in the third trimester on the right side, you see that the baby shown in the black shaded area, the baby's red blood cell mass increases and the mom and baby combined, they need extra iron to make more red blood cells. Well, I should say that's the mom's red blood cells, sorry, and the baby's, the placenta's red blood cell, the placenta's iron requirement is shown in the white area on the top right, showing that the pregnancy requires the mom to use a lot of extra iron. And it's as much as a third of the mom's iron. And if the mother starts off iron deficient, then she doesn't have iron to give the baby and the placenta and her own, and not enough iron for herself to make more blood. And the concept is that iron deficiency is common in pregnancy. We're seeing that as many as 25 or 30% of all pregnant women have a significant degree of iron deficiency. And a much more important concept might be that the baby wouldn't get enough iron. And that's shown here. This says 30 to 40%. That's worldwide. Pregnant women have significant iron deficiency. In the US, we feel it's more 25, 30%. That'd be 1 million women a year, 1 million. And there's known to be, or now felt to be, a significant risk of maternal morbidity and mortality, including preterm labor, postpartum depression. And mortality, I say, the mortality would be women who start off so low that they can't make blood, and then they come in to deliver their baby. And when you lose another half liter of blood, a woman could die of bleeding if she doesn't have enough blood, like a reserve of blood and iron. So that's where we're giving blood transfusions, and that's the second leading cause of mortality, of peripartum mortality, is bleeding. The third bullet talks about perinatal, and that's what I'm getting at, perinatal morbidity, mortality. And the fourth bullet talks about the neurologic development of the infant. It's felt to be a problem that babies who are born iron deficient may have impaired neurologic development and delayed milestones, and even there's a concept that's put out there that autism is maybe partly related to iron deficiency in babies. So the UK guidelines have talked about this, and we have guidelines too, but we're in the US, we're a little behind, and we're talking about, we're finally doing clinical trials of treating women with intravenous iron, but we still don't have those trials done in a way that satisfies all these, that answers all these questions. So iron deficiency in general, and particularly in pregnant women, is associated with being tired, weak, having palpitations, having headaches, being short-winded. I noted on the third bullet from the bottom, craving ice, that's a big one. Disturbed sleep, impaired concentration. I think that most of us have just come to accept that pregnant women might not feel like themselves, and they might be tired, and it just became normal to think that it's okay to just be tired and short-winded when you're pregnant. But a lot of times it turns out to be iron deficient. And then the big one is that if a woman is craving ice, I just start off my conversation asking, how much ice do you chew? And that's to be honest with you, that's the biggest sign of iron deficiency that we have in pregnancy. If you want a little more detail about interpreting the test, once I get the test, the iron sat less than 20% is a tip-off. The TIBC more than 450, that's the total iron binding capacity, the denominator for the iron saturation. These are the normal ranges. If it's more than 450, it might be iron deficient. I sometimes use my hematology judgment and say, well, if it's 470, don't get excited about it. But if it's in a pregnant woman, but if it's 550, 600, then it's a problem. If the MCV is low, remember that the MCV can be low from alpha thalassemia. So you have to use your judgment and put it all into context, but it's most commonly iron deficiency. If the ferritin is low in a pregnant woman or any young woman, that's usually iron deficient. And finally, the ice craving. And the challenge is that sometimes, particularly in pregnancy, these tests don't all align to make the story clear. And one of the reasons that a hematologist is important is that I have so much experience with this that I can put it all together and say, well, this picture looks like iron deficiency, and decide when it needs intervention. And what I say, just to put this out there, is that any two of these tests is probably enough to feel confident that it is iron deficiency. So if in a pregnant woman in particular, you see the ferritin low, TIBC high, but sometimes the iron sat doesn't fit. Like there's a different way to interpret it in pregnant women if their iron sat's normal looking, but the TIBC is high. So lots of things here, nuances to it, but one of the reasons that I think it's important to have a telemedicine hematologist available. So this is what we do. We see the patient online within a day or two of requesting it, so that we make everybody happy. We try to please, we're kind of concierge. We try to please the OBGYN provider who gets their patients seen quickly, and we're their partner. we please the patient who's suffering and maybe craving ice and tired, and they get seen quickly. We review and explain the labs. We help the patient decide whether IV iron is needed, and we have algorithms which more or less say that any third trimester woman who's iron deficient needs IV iron. That's more or less the algorithm, with some exceptions. And we plan the IV iron infusions. Now, the gap, the unmet need in iron deficiency anemia care was both the hematologist to prescribe the iron and the actual infusions to get the iron. Both of these were gaps. I will say that we are finding ways to get this iron infusion done, including our own infusion centers in South Florida, and pairing and partnering with all the infusion centers that have popped up for different reasons around the country. So we're accomplishing this. It's been a feat to get it done, and in the past year, we've seen 600 outpatients as a start to our telemedicine outpatient practice, and we've had 230 infusions, iron infused patients, mostly pregnant, many that are not pregnant, but the majority pregnant. And we are solving this problem, and we are aiming to solve it for all million pregnant women and 20 million maybe women that have iron deficiency out there with heavy menstrual bleeding. I consider these to be public health problems that we need to solve. And importantly, we communicate with the provider who referred the patient about their patient, so they know what's going on. This is our marketing material. We take care of it all, including those women who have heavy menstrual bleeding. It's thought to be as many as 1 in 10 women who are iron deficient related to heavy menstrual bleeding. And we can solve that problem too. This is our marketing material just to tell the OBGYN doctors who to refer, or family medicine or other primary care providers. Refer your patients who have iron deficiency or any other blood disorder. Now I'm going to go through a short presentation about the benefits and drawbacks of telemedicine hematology, and then I'll open it up to questions. And I'm all excited about our approach to iron deficiency anemia, that we're going to solve this. I consider this to be a public health problem, that so many million women and pregnant women are iron deficient, and there really wasn't a way to solve that before with the in-person system. So I'll start with the basics on telemedicine. It's obvious that we're providing more access, and we're able to see people anywhere they are, anywhere I am. It's really honestly very convenient for me and very convenient for patients. I don't have to stop what I'm doing to go to see a patient in the hospital. If I happen to be in a car, I do a televisit in the car. That just happens now, and it's part of our world. I try to be in my home office so that I'm doing it, more officially, but it's not required. Great that there's no infection risk. I am not worried about getting infection, no COVID for me if I'm seeing patients online. Now I'll come to the main drawbacks, and I'll go through a little more detail about all of this. And these are things that we've come to accept and appreciate. I'm sure all of us are doing telemedicine. We're all on the GPT call here. We are accepting the fact that we're not in person to do the physical exam. And as I've told you, hematology lends itself to this because we're focused on numbers and data and lab tests and a lot of times imaging studies and the history. I feel very comfortable with not doing in-person physical exams. And I'll say that we're still doing a lot of physical exam just by seeing a patient online. And, you may argue with me about whether I need to palpate the spleen and lymph nodes, but I'm pretty good with what I see online, whether a patient's with it and able to talk to me and knows what's going on. That's a big part of the physical exam. And whether they have significant bruising, I can do a skin exam online. Whether they have, just abdominal distension, I can have them point to their phone to their belly. I can have them point to their legs, leg swelling, DVT. So I'm getting a lot done, but I do recognize that it's a limitation. And I will put out there that there have been patients that I tell online that they need to see an in-person hematologist because I don't feel comfortable with what I'm seeing. So the second issue is the lack of awareness of vital signs. I recognize it's a problem that I don't have the pulse and temperature and heart rate and the blood pressure rather. And I have just come to accept that the patients I'm seeing are hopefully not sick enough to worry about it. I don't ask the patients to take their blood pressure at home for my purposes. If they happen to, that's great. I sometimes want them to weigh themselves for one reason or another, and that's common for people that have scale. But we've gotten past this. We accept the fact that telemedicine has these limitations, and I think all of us have to just appreciate these limitations and tell people to go to see in-person providers when we feel uncomfortable. And then I think most important, especially for hematology, where I'm dealing with blood cancer sometimes, um, that we have this lack of in-person interaction. That's a problem. We're giving bad news, and I would go as far as to say that this is the biggest problem with telemedicine. And you might say, well, it's cold this way, that we can't hold their hand and hug somebody when we're giving bad news. But the benefits of when we're giving bad news and we're able to, for example, have their patient, have their family in the call, and have remote family members come in for a Zoom-like call, that's a benefit that wasn't that achievable before. And there are benefits aside from the fact that I can see somebody online within a day and they don't have to wait to see me for the bad news in person, a week later, or a phone call, which would have been all the worse for bad news. So I'll go as far as to say that the benefits outweigh the problems here, but there have been cases where I wish I were in person with a patient. Now I'm going to go through another list of the benefits that I've enumerated, and maybe you'll agree with some of this, and then I'll take your questions after about these issues. The benefits of before I see the patient, this is a list of things that I've come up with, and there could be more, but the patients can be seen more promptly because I'm not actually wasting time going to hospitals, seeing patients, inpatients. I do it all online, so I can see them. That's one of the reasons I can see people within a day. I can see, of course, patients that have no access to specialists. The third bullet says that I can have their medical records sent to me by email. So I have assistants that help collect my medical records, that I'm able to organize things without making phone calls myself. Patients can be prepared with their own list before they see the doctor. They don't have to be, they can concentrate their questions. And finally, they don't need to miss work to see me online. I see people at work sometimes on the job. They take a few minutes out and go to a private area and get seen. So lots of benefits there. That's pretty obvious stuff. Now, during the televisit, I find that patients are less nervous seeing me in front of their computer than they are with the white coat anxiety deal in a doctor's office. And I find that the patients are more comfortable in their home environment. And it may not be universally true, but it's really made a difference. I think that people they just are able to talk more easily. I mentioned already that family members can be on the call. And I think that's a huge benefit. Whenever somebody asks me about a family member, I just send a link. They literally they have the family member get texted a link and they join the call. And just like a Zoom type joint call, group call. And it's made a difference. A lot of times I have young people young adults who want their parents in, and the opposite. I have older adults who want their adult children in. And I'm able to do these calls, and it makes a huge difference. Explaining things to people that may have questions, and they can support their loved one with their challenging news or their difficult diagnosis, especially with the bad news. And then infection transmission, of course, is a big thing. We don't have that telemedicine. And finally, I think it's a nice advantage that I can see the patient's home environment and provide recommendations about how they can do better at home. Like if they have challenge, if they have stairs to go up, and think about a little more in front of my eyes what's going on in their house. A lot of times I find they have a lot of noise in their house, which is something I hope to overcome. The challenge of telemedicine is dealing with that and telling people to go to a quiet area. But when they have so much noise, I think it's a stressor for patients, and I tell them to find a way to make their house quieter if there's too much noise. Now, I also, the fourth bullet, I talk about patients' lab tests all the time, and I share a screen and show them their lab tests, and showing data, it helps everybody. We all embrace data, and it's different to be able to tell them versus to actually show them. And I offer them the option of sharing, taking a screenshot. I tell them, if you want to have these to look at later, if they don't have them ready, take a screenshot on their phone, or I'll email them their lab data if they don't have it. After the televisit, it's beautiful that I can see people as often as they need. I'm seeing some people once a week, but this is not something we're abusing. For people that have chronic diseases or abnormal blood counts that I'm worried about, I see them once a week, once every 2 weeks, but it's really not that common. The key is to try to help people avoid hospitalization and readmission to the hospital. And that's a big part of our modern medicine push. And those who are discharged from the hospital, I can see within a day of discharge, and then I can see them every week if they need it, to try to keep them out of the hospital. And then they can email me afterward, and we go back and forth with email to have continuous communication. I think it's a big deal that we can see people in the evenings and weekends because we don't have office staff required to do televisits. My office staff work from home, and they see people. They help people during the daytime during the office hours, but then I can see people in the evenings if I choose. And it changed the world like that. People like that a lot, and I like that as a provider, willing to sacrifice some evening time. And then finally, patients can have more services at home and decrease the cost of services. And I think that's a great thing for people that have difficulty getting out of their house and getting infusions in their house, if possible, or getting lab tests in their house. And I find that the payers, the health plans are finding this to be attractive, and they like that I'm offering this. I'm trying to match people with home services to make it, if nothing else, less expensive for everybody. I see a question, I'll just address it. Am I using on-site assistance in the home um, where our home paramedics support telehealth visits and blood draws are needed? I do use um, I do use on-site assistance, like having people go to their house for services, but I don't use on-site assistance for the live televisits. Only the patient's family. I don't coordinate an on-site provide assistant, although that is something that's being talked about for particularly for elderly patients or those that have difficulty getting online. And there will probably be that kind of service available in the future, much more readily. And then my last slide, I'm going to talk about the drawbacks here, and then we'll open it up to more questions. So there are many more drawbacks, but I will enumerate these and talk about these. I call these the new problems in the modern era. So, and the top one I think is the biggest, really one of the biggest ones for me anyway. There is this weirdness that has come about because of the telemedicine flow system, the workflow of telemedicine. When a patient has a 5 p.m. appointment, they expect me to be there at 5 p.m. So I sort of invented this challenge of, if I'm late, what's going to happen? Who's going to tell the patient? There's no medical assistant to tell the patient the doctor's late. There's no actual physical waiting room. It should be all the easier for people to wait because they're in their house. There are solutions out there, like I could have the patient get texted when I'm ready for them. Um, what I do is I have a chat area in my telemedicine platform, and I chat to them. I'm running late, aware that you're waiting, thank you for your patience, this kind of thing. But it's a lot of multitasking for me as a solo telemedicine provider without, an online helper. And I could have an online helper, but I haven't felt that's worth it just yet. So it's a weird thing that the waiting room, people expect me to be on time. The opposite is happening too. I expect the patient to be kind of on time. We have this kind of 5-minute wiggle room, but that's the era that we're in. If the patient's 5 minutes late, I start calling them and saying, hey, what's up? Did you forget your televisit? And people, the beautiful thing about this outpatient telemedicine practice is that hardly anyone is intentionally skipping an appointment. They have paid a copay in advance, so that, probably makes them more interested in their appointment. But if people miss their appointment, it's because they forgot or they fell asleep sometimes at their house. And it's not that they're intentionally missing it. So I think it's weird that there's this thing about being late, but we solve it. We do the best we can, and we work around it. The second issue, the access to care, we're creating a new problem that really a different version of an old problem. There's this thing called the digital desert, which is the area of the country, the rural area, here we are talking to GPT, where patients don't have access to Wi-Fi or 5G. And I think that's shrinking, but that digital desert is still there, and we have people that don't have real access. And now we're just saying, well, we'll do a phone call and see how it goes wherever we have to. I do have patients in rural Florida and Georgia who just can't get online on a video call, even though they have a smartphone. Now, the digital divide is the people who don't have an actual smartphone or device. And there's going to be that no matter what. There are going to be people that can't afford a device, older people who can't use a device and can't figure it out. I think there's going to be that for a long time, that digital divide. And I mentioned already the concept of having someone go to a patient's house to get them online. That will probably be something that happens aside from the patient's family. Usually there's someone in the family that can do it. But I have patients that can't get online. And the bullets I have under that, are there certain ethnic groups or older people that are limited? Yes. and we're creating a new problem with equity, healthcare equity. And then the bullet below that is telephone medicine is good. We've done telephone medicine for decades, but now we're talking about keeping it because and embracing it because we have patients that we want to do telemedicine but can't. So I don't think it's as good. I like to see the patient. They need to see me. They need to see my face. So I don't like telephone medicine, but we do it where we have to, and I think that'll be solved over time. Then the second to last, will CMS and health plans continue to cover outpatient telemedicine? That's just a looming question that none of us have the answer, and I don't have the answer. And though the way I see it, the longer we get used to telemedicine, the more they have to cover it. So I think all of us agree that there will be coverage, but will it one day decrease and be less coverage than in person? We don't know. And the final question here, how will interstate televisits be dealt with? We already see that states are tightening it up, and they're going to be saying that you can't practice medicine across state lines without a license in their state. Up to this point, for the past year, COVID-19, really no one cared. There's some states that didn't officially allow it, but no one cared. You can do telemedicine anywhere across the country, and the whole state licensing issue, a whole other lecture that I can provide here. But the general idea is that we telemedicine providers for the moment will need to provide to get state licenses in every state in which we want to provide a televisit. Now, if my Miami patient travels to Georgia and I don't have a Georgia license, I feel comfortable seeing them online because they're my patient, even though there's some lines blurred there. But in the future, I'll need to have more state licenses and I've already have many myself but to cover everybody, all my patients who travel, and also I want to do telemedicine in every state. I think there's a need for it. And the way I see it, I think that every need needs to be met. So why are states going to stop me if I'm providing a need that's an unmet need in their state? But we'll have to solve that. Believe it or not, that's the end of the presentation that I have planned for you. And I'll just summarize and say that telemedicine hematology is feasible for patients with all the non-malignant heme conditions that I've enumerated, including iron deficiency, clotting, bleeding, myeloproliferative disorder, sickle cell disease, and certain heme malignancy type patients. I believe, and I think I've convinced you, I hope that the public health challenges like iron deficiency anemia can now be solved by providing telemedicine hematology services and ultimately a larger presence of infusion centers that can provide infusions that are not specifically connected to heme practices. And finally, that telemedicine is here to stay, but we have some issues to solve. I will start with questions, and I already see a question about my iron story, and thank you for that. The question is, how does ice craving identify as iron deficiency? And the answer to that is that there is a strong correlation between iron deficiency anemia and ice craving. And the term pica suggests that you have craving for things that are not food. Technically, ice is not food. And the concept is that, the reality is that ice craving is very strongly correlated with iron deficiency, and in fact, probably caused by iron deficiency. And if the question is, why does that happen? The answer is, I think no one knows. But it just goes to show that iron deficiency is causing cognitive problems and even problems that are below cognition, like food craving. And it's affecting your brain. It's affecting your concentration, your memory, your ability to sleep. And it does, in fact, have a strong correlation with iron deficiency. So I'll say that iron deficiency and ice craving go enough together that I use it as part of my diagnostic criteria, or my prognostic criteria for who needs IV iron, because somebody with iron deficiency who's craving ice is very bad. And that's a lot of people and a lot of pregnant women. Another question I have, has your practice seen an increase in referrals from hospitals related to COVID patients and clotting issues? Thank you for that. Let's talk about COVID-19 and clotting, although it's not the focus of our discussion today. I'll clarify as a hematologist that there is a strong relationship between COVID-19 infection and DVT-PE and other clots. And we're seeing all kinds of clots, including stroke. And it's a strong relationship. It isn't saying that everyone COVID-19 is getting clots, but it's happening. We now appreciate this and are ready for the past year. And so we do recommend anticoagulants for COVID-19 patients who are sick with COVID-19 in the hospital and after discharge as well. Many of us recommend. I don't get a lot of those consults in the hospitals in which I work. I think that the hospitalists are on top of this, but I welcome those consults and the decision making about inpatient COVID-19 questions. And then when someone's discharged, I can see them online within a day as a clot consult for a COVID-19 patient who has a clot or a COVID-19 patient who's concerned about clotting. And I would be able to do those consults and talk about clotting and do that education and prescriptions for anticoagulants. I haven't seen a lot of those consults, but I do think they should be coming my way. And then I will tell you what's happened the past few weeks. I mentioned already that the COVID-19 vaccines are talked about for clotting. And I'll put this out there now that so far the main story is the Janssen vaccine, the Johnson & Johnson, as you've already no doubt heard. There's an association between the syndrome now called vaccine-induced thrombotic thrombocytopenia, which is clotting related to the Johnson & Johnson vaccine and the AstraZeneca vaccine in Europe and outside the US. And that specific entity is really very, very uncommon and very limited to special cases, and that's seen in patients. I would be the first to identify it for an inpatient in whom we're seeing that phenomenon if it came to my attention. But it's not something I'm seeing as an outpatient thing. I am getting a lot of questions about vaccines in general for outpatient. And my answer in general is that the Johnson & Johnson vaccine has that special case, but otherwise we're not seeing a pattern that's so important about vaccines causing clotting outside of that situation with the VITT Johnson & Johnson. So the Moderna and Pfizer vaccines are not known to be specifically related to clotting. Although anybody who has had a clotting tendency in the past has to be worried about anything they do to their body. And it's something that we do pay attention to. So on a one-on-one basis as a consultant, I would be counseling people and guiding them about anticoagulant decisions for any situation.